Morning, everyone. Welcome to our UCSF Urology Grand Rounds. We're very excited this morning to have some special speakers, and there are chief residents who are going to be graduating in one short month and going off into their post-residency lives. And we get the real special opportunity to hear from them about work that they did during their residency and research year. We're very fortunate at our UCSF to have a dedicated research year for our residents, and that's something that's becoming more and more uncommon in programs nationally, and we're one of the very few who still maintain our commitment to this. So really excited to hear from our chiefs about the work they've done, and first I'm going to welcome Dr. Ashwin Balakrishnan to come talk about his research.
Good morning, everybody. So when I started my research year, we, as everybody knows, we kind of set out a plan from the beginning, starting a year ahead. And this wasn't actually one of the projects that I had initially thought I would really focus on. And because Dr. Bain invited me to participate in it kind of later in my fourth year. But I'm really glad that he got me involved, because this ended up being a very meaningful project for me, at least, and hopefully for our partners in Uganda. The project is titled Low-Cost 3D Renal Model is Effective and Reproducible for Endourology Training in a Resource-Limited Setting. And, just to go through some of the main players in this project, Shiv Patel was a medical student who was very involved and helped me with developing the model. Unfortunately, he chose not to do urology. He's going to do anesthesia, but there still might be time for him to change his mind. Kit Yuen was a fellow an oncology fellow actually at San Diego, who worked with us closely on administering the training in Uganda. And then everyone knows Ian Metzler, who now is who is a resident here and now attending in Oregon. So this project was really built on the work by Dr. Metzler and Bain, who have done a lot of work to improve endourology training in low and middle income countries by developing low-cost models that are kind of centered at those trainings. So at the start of my research year, Dr. Bain involved me in his work with the CHESA group and Mulago Hospital in Kampala, Uganda. So as you can imagine, in Uganda, open surgery is more widely utilized in the management of upper tract stones than in the US, where we typically use endoscopic approaches and where these approaches are widely trained. We've seen that in Uganda and other low and middle income countries, endourology equipment like scopes, dilators, wires, etc., have become increasingly available. However, to do these cases in Mulago and other hospitals, it can be difficult to obtain other equipment, notably C-arms, because they're heavily utilized by other services. So this is a direct quote from one of the urologists that we worked with, is our hospital has 3 C-arms and all belong to orthopedics. 2 are often dead and only 1 is functional, and they don't allow us to readily use their C-arms. So enter ultrasound. Ultrasound is more available and has gained traction as a more cost-effective and accessible imaging tool across specialties, but especially for endourology procedures. However, in Uganda, most urologists lack training in ultrasound-guided techniques. So the objective of our project was really to develop an ultra-low-cost, easily replicable, and ultrasound-compatible model of the kidney and the flank to facilitate training in ultrasound-guided techniques for both percutaneous access and ureteroscopy to confirm positioning in where you are in the kidney when you're doing ureteroscopy or stent placement. So and to make sure that this model could be used in trainings with our partners in Uganda and other sites across the world. So we aim to use materials that were easy to obtain globally. That you can't just go all over the world. You can't just go and order materials on Amazon like you can here. So we had to make sure that they were accessible and to make it easy to reproduce those models so they could be generated by local teams of urologists. So this is kind of where we started. So this is a very early iteration where we developed 2 3D printed molds, one of the human kidney and another of the flank, that simulated both the flank, the proximal ureter, and also doing surgery in the prone position. So we first started with just the kidney mold. You can see that in the left-sided image, which we designed using CAD. And then after we printed the kidney mold with a 3D printer, we poured ballistic gel into that mold. And we did early testing by just submerging it in water, ultrasounding it, and just doing basic navigation of it with a flexible ureteroscope. You can see on the left, the ultrasound image of that basic anatomy of the kidney initially. So it was ultrasoundable. And then we added other elements. So from there, we added a renal pelvis, a proximal ureter, and to do that, we had to 3D print a mold of that would exactly fit the kidney mold that we had developed. And here you can see we experimented early on with various low-cost materials, right? So we thought about using a Penrose drain for the renal or for the ureter. It ended up being a little too cumbersome to assemble, and we worried that it wouldn't be easily reproducible, so we ended up getting rid of that. But just wanted to show you some of the early prototyping. But then for our final iteration, we encased the ballistic gel kidney model in a flank model made of gelatin, which you can see above. And here on the left side, you can see the mold filling with the cooling gelatin, and then you can see the final product with the kidney encased in the gelatin mold. So this combined model was then placed in a water bath so that the renal collecting system could fill with water and appear as urine on the ultrasound. The renal collecting system ureter could also be instrumented with a ureteroscope. So the total material cost for the final product was about $30. So here you can see in the early versioning of it, the kind of the ureteroscope navigating into the model, and then this is lent to us by Boston Scientific so that we could do this early testing. You can see flexing down into the lower pole of the kidney, and then coming back into the pelvis. And then this is what the ultrasound visualization looked like. You can see in the mid pole of the kidney, the ureteroscope moving. So when you don't have a C-arm and you want to confirm where a stent is or where your ureteroscope is in what aspect of the kidney, this can be very useful to practice. And then you can see here what our early kind of testing of needle access looked like. You can see the needle in the renal pelvis, and then navigating the ureteroscope simultaneously into the kidney to see where your kidney is actually entering, which is a technique we were taught at UCSF. So then, after we had developed this model and felt confident and tested it out, made sure it had the Dr. Stoller stamp of approval, we traveled to Uganda, which I was very fortunate to do with Dr. Bain, and organized a training with 12 urologists, which was not an easy feat. We were very grateful that people traveled so far to attend this training, and it really spoke to the need for this type of training in Uganda, that people came from all over the country, and actually one urologist even came from Ethiopia. So this was a 3-hour training which I had planned and detailed with Dr. Bain, and prior work that Dr. Bain had done in Uganda really contributed to how we organized this, and that work had shown that basic ultrasound skills can be taught efficiently, and this was even just taught virtually with focused trainings, and led to improvement in task completion times. So we really drew upon this work to structure our trainings. We also learned from prior research that had been done on the use of standardized terminology when teaching PCNL, and this really came from teaching with residents here at UCSF, right? And sometimes it can be very difficult to articulate how exactly you want to move the probe, how you want people to move the needle. So standardizing that language can be very helpful when you do these focus trainings, and really contributed to the structure of this training. So we started with our session with a 30-minute detailed instruction on how to use the model, the ultrasound equipment that was available, the supplies such as the access needles, the wires, and then had some demonstrations of ultrasound guided access and ureteroscopy. We administered pre and post training surveys to to evaluate participants' procedural confidence, their background, their skill level, whether they were trainees or attendings, and their task completion times. So this is kind of just a video just showing Dr. Bain giving some instruction on the ureteroscopy training module of our session. He's saying that the trainee is lost in the gelatin. So this is very valuable feedback. There's some additional photos from the session, so you can see Kit, who is doing some instruction on the percutaneous access model, and then also the ureteroscopy model. So going through some of our results, so only one participant surprisingly had prior training in flexible ureteroscopy and formal training. Other people had done it, but no one had really received any formal training, just kind of learned on the fly. And only 3, so 25%, had prior training in percutaneous access, whether that's for PCNL or nephrostomy tube placement. And the latter was the more common procedure, nephrostomy tube placement, where ultrasound was used. So despite access to functional ultrasound machines, participants primarily only use them for prostate biopsy. So 2 participants, and like I said, nephrostomy tube placement. And post-training, you know, we looked at a lot of different variables, but you know, one that stood out to us was urologists demonstrated a significant increase in confidence for both ultrasound-guided perc access and also for confident ureteroscopy of all 3 poles of the kidney, and confirmation that they were in the various poles with ultrasound. So, you know, we received a lot of good feedback about the model itself, about the training. Some of the things that came up to help us improve the model fidelity, and which we've already implemented, is, as you might have noticed, the KLCs were in plane, and you know, and it was easier to print that type of a model. So we've now made them more skewed to resemble the actual anatomy of the kidney, with anterior and posterior KLCs. And you know, we haven't elongated the ureter because we're very limited by our printing mold. The 3D printer can only print. We maximize the size of what we could print, so we really need to get a better 3D printer or have access to one, so we could print a longer ureter. And then adding opacity to the gelatin, obscuring the model, that was very easy to do. Dr. Metzler suggested just adding chinchilla dust to the others have used Metamucil, so you can still keep it very, very low cost. You know, just using some psyllium husk even to just opacify the model. So, but you know, and then the most consistent positive feedback we got, I mean, people felt that it was very helpful, but they just wanted more time to practice on the model. Everybody, you know, was very excited to have this as a tool that they keep using to practice these procedures. So here you can see in this photo, one of the participants just practicing generating the model, which is, you know, I did with 2 of the urologists there. We left a 3D printed mold with them, and then we just trained on fabricating the model, which is very easy to do, and pouring the gelatin in the model and creating it. So there were some tweaks that we did to the mold to make it even easier after we saw some hiccups with this mold, I mean. And you know, future next steps will be follow-up assessments to see how this is continually used, and assessing proficiency with both fabricating, using, and implementing their own training. So we were hoping in February to do another to assess how this is going. Unfortunately, there was a small Ebola outbreak, and Dr. Bain wasn't able to go. But you know, this is a continued partnership, and we're very excited to see how this pans out. And you know, if there's any junior resident that also wants to get involved and help with continuing this project, we're very excited to have that participation. So just wanted to acknowledge some of the 12 Ugandan colleagues who participated in this session. Chessa for providing the funding for me to get out there, and you know, Dr. Bain was very instrumental in coordinating that. Very grateful to him. Boston Scientific for providing some of the materials, and some of these other groups that were involved. Thanks everybody, and I'll open it for questions.
it's a great project that you guys all have. Do you leave an ultrasound machine there, or do you donate one, or do you buy one, or get someone to donate ultrasound machines there?
They already had an ultrasound machine. I'm not sure the exact funding for that, for how those were obtained, but maybe Dr. Bain knows.
So the hospital, it's the national hospital, so they do have ultrasound machines, which are more readily available. For us.
Is there a way to get additional ultrasound machines for other urologists there to have people come there?
I'm sure that they would be open to that. You know, we've as part of other research that we've done, we showed that using the butterfly and even more low cost ultrasound machines we can do P&Ls with them, right? And you know, when we were at the county, we did that, and you know, that's something that if cost and access to the existing machines becomes an issue, we can even further lower the cost, right?
What's the access to these endoscopes? How readily people in the countryside, the main hospitals,
Yeah, it's a great question. So for the ureteroscopes, my understanding is, so there's no disposable ureteroscopes, right? Obviously, disposable. You know, when you go there, you like, it's just shocking to see the differences in equipment, right? And the reuse of what we consider disposable wires, etc. With the flexible ureteroscopes, they were actually owned by the urologists themselves. Yeah, and they were used in the university hospital here, and also in their own private hospital, their private practices. So yeah, the ureteroscopes are owned by the urologist. The P&L, the nephroscopes, I believe, are owned by the hospital. They're easy. Those are, you know, and you kind of see that in other low income setting, in middle income settings as well. I know, you know, through some research I looked at in India, you know, it's much easier to obtain the nephroscopes than the ureteroscopes, and also, as we all know, they don't break as easily. So, you know, mini P&L, ultra mini P&L is more utilized that for stones often than the ureteroscopes.
85 ballistics gel in Uganda? Like, where did that come from?
Yeah, actually, it is. You can actually order it online. Yeah. So you can't go to the market and get it like gelatin, but you know, the two folks that we trained to use to fabricate the models, they're not doing that because we just gave them, we just left behind the ballistic models, and those last a long time. I don't know the exact, can't give you a number on how many punctures before they lose fidelity, but they last much longer than the gelatin, right? The gelatin is kind of just for one session at a time, because if you leave it out, it's gonna rot. Yeah. All right, thank you.
You know how to do this. Okay, great. Next, we're going to welcome up our next chief resident, Dr. Adrian Fernandez, to talk to us about his research here.
This is okay.
Thank you.
Okay, awesome. Thanks everybody. Thanks Karen for setting this up, and Dr. Hampson for introducing me. So I'm Adrian. I'm one of the chief residents here, and I wanted to just start off by kind of explaining my approach to research here. It was maybe a little bit different than some prior residents, and the best way that I have to explain this was actually something that Alan Schindel said. He said, Adrian, you're actually doing research tapas style. So what I eventually ended up doing is a lot of different projects. Most of them were with large databases. So my focuses there were in spina bifida, in implantable medical device safety, in electric bicycles, and then a bunch of sperm studies as well. But in addition to that, I got to practice some grant writing, particularly with Drs. Kopp and Hampson. I did some data visualization studies with Dr. Cooperberg. I was part of the CHESA Fellowship for Health Equity. And on more of a personal level, I got to learn to do some oil painting with my dad. And then most importantly, made a little cutie named David. I'm going to start off by talking about some of the projects that we did with the group that focuses on spina bifida and healthcare utilization. The team is led by this power couple right here, Dr. Hampson and Dr. Kopp, who in 2017 started the Lifetime Congenital Urology program. That is a clinical program that essentially transitions people with congenital urologic problems into adulthood. As people know, Dr. Kopp is a pediatric urologist. Dr. Hampson is a reconstructive urologist, so that symbiosis really reflects the fact that people with spina bifida in this time and in this place tend to live for a long period of time. And so the issues that are present in kids with spina bifida become issues that present later on in adults. So the project that I'm going to share from this work is about emergency department visits in adults and kids with spina bifida. Our hypothesis was that individuals with spina bifida have higher ED utilization than people in the general population. The rationale for this, is pretty clear cut, but essentially there are a lot of different things that intersect among individuals with spina bifida that can predispose them to high healthcare utilization. So sequelae of congenital medical problems, for example. So the neurogenic bladder, neurogenic bowel can predispose people, for example, to UTIs, and then also treatments that those people have had in the past. For example, people with urinary diversion or ventriculoperitoneal shunts, those things can get infected or have issues. That kind of interrelates with the cognitive challenges that sometimes limit self-care or the medical systems in our country that provide great wraparound care to kids with spina bifida, but not so much for adults. So the research project was essentially interested in how do all of these things manifest in terms of healthcare utilization for emergency department visits. Our objective was to use the database HCHI to compare ED encounters and the causes for those ED encounters in spina bifida versus birth year match control individuals. And just a little background on HCHI. So there's a California state-funded initiative. It is intended to expand equitable healthcare access. And what it does is it's extremely comprehensive in the sense that it captures all inpatient hospital, emergency department, or outpatient surgery center encounters across California. So it includes diagnoses, treatments, charges, disposition from those hospitalizations. And I just want to highlight here, Debbie Goldberg is the data scientist with our group, and she was kind of my partner in crime with all of this data analysis here. So what did we find? We were able to identify 2,290 individuals with spina bifida in California who sought medical care at inpatient hospitals, EDs, or outpatient surgery centers between 2005 and 2017. We matched them to a group of individuals in the general population, 5 to 1. So 20,000 patients with individuals with spina bifida, a little over 100,000 controls. And then in terms of ED encounters for those people, there were about 290,000 with spina bifida, 410,000 controls, and the mean ED encounters for people with spina bifida was a total of 13 versus 4 in the control group, and median ED encounters was 5 for individuals with spina bifida versus controls. Just putting this visually, we used a violin plot here, which on the x-axis shows kind of the frequency of people in that cohort that had that number of ED visits versus the actual number of ED visits here on the Y axis. And you can see that in the control population, there were a lot more people with fewer ED encounters compared to those with spina bifida. Note the log scale here on the y-axis. If you plot this out by age, what you can see is that there's a really dramatic difference across all ages, but in particular, I want you to focus here on this age group. You see this dramatic increase in ED encounters among, both control groups and people with spina bifida as they age out of pediatric care. But you see that most dramatic increase in individuals with spina bifida in this age group, possibly reflecting that the lack of wraparound services as people transition to adult care manifests as more ED utilization in that group. We were able to publish these results in the American Journal of Preventive Medicine. And there are a lot of other projects. I wanted to include more, but based on time, I won't be able to. The next project I want to talk about is a grant. This is just kind of a personal story more than anything, but there was a really great CDC grant opportunity that would have focused on statewide population level surveillance of people with spina bifida. It was right in the wheelhouse of what we were doing with our group. It was a $2.25 million grant that would have been awarded over 5 years. And I want to highlight the work of my collaborator here, Than, who's going to MGH next year for urology training. In order to satisfy the goals of the grant, he and I together came up with a list of a bunch of different databases that we could use to essentially link together in order to identify people with spina bifida across the country. So we have California's birth defects monitoring program, UCSF's own registry, the LCUP registry, HCI, and then Medi-Cal, Medicare, and public health records. All of these together would have given us a really incredible insight into, across the lifespan, what kind of medical treatments do these people with spina bifida end up needing? What are basically, when do they pass away? What kind of medicines do they need? What kind of treatments do they get? And we came up with a proposed way of linking all of these databases in order to create something that we called the Spina Bifida Insight Cohort in order to track their health outcomes over time. This was the outcome, which was that our $2 million grant was recommended for approval, but the funds were not available. So this was really shocking and disappointing. It was kind of a WTF moment, but I really applaud the work that we did. This was like about 3 months of my life putting this together, and we're still going to be able to use our plans to get more work done. I'm going to transition now to talking about some of the work with electric bikes. This was spearheaded by our fearless leader over here, the strapping Dr. Breyer. In terms of e-bike injury trends, as we all know, living here in San Francisco, e-bikes are basically everywhere. So our hypothesis was that in recent years, e-bike injuries have increased, and we were curious, hey, is this a national trend or just something that we're seeing here in San Francisco? Our rationale, it's right in front of us, but also, as you can see here, in these e-bike sharing programs, you just get the bike. It's not like you get a helmet or any tutorial on how to use these things. So we were thinking, hey, maybe this could be a something that is causing harm to people. Objective, we wanted to trend e-bike related injuries and hospitalizations in the US. And for this, the database that we used was NEISS, which is basically a database managed by the US Consumer Product Safety Commission. What it does is it provides national estimates for injuries related to US consumer products. It takes a sample of 100 emergency rooms, and then that has been designed to be nationally representative. And the database includes some short narratives about what happened to the patients and the products involved. Kevin Lee, who will be joining us next year, I'm really happy to say, was my kind of co-conspirator for this project. And what we found here was that there was this incredibly dramatic spike in injuries related to e-bikes. So here the gold is injuries, the red is hospitalizations. And what we found going from 2017 to 2022 was that there was a 30-fold rise in e-bike related injuries nationally. That was about 100% each year compared to the last year. And then there was also a 43-fold increase in hospitalizations year over year, over the entire period, 108% annually. The odds of sustaining a head injury for non-helmeted e-bicyclists was about 1.9 times higher compared to those that wore helmets. We went through all of these narratives to see who was wearing a helmet, who wasn't. And then the odds of helmet use actually decreased by 5.6% each year. Lastly, the incidence of head trauma actually outpaced the incidence of e-bike injuries. And so that was about 49-fold higher than in 2022 than 2017. We were interested in kind of tracking this compared to other micromobility vehicles after we published this work in JAMA Surgery. And in doing so, we were able to essentially track some of the demographics of who are using these new electric vehicles. And we were able to analyze that helmet use in electric vehicles was a little bit less common than in the conventional bikes and scooters. E-vehicle injuries were also more common in urban settings, and it was typically people that were a little bit older using the electric vehicles compared to conventional vehicles. And finally, this was kind of something that we were not really planning to look into, but we found that the age-adjusted odds of hospitalization among individuals of Black race compared to white race was only 0.76. So for every 100 people that were hospitalized for an injury related to these vehicles that were white, only 76 people that were Black were admitted. So, definitely kind of an area for future research, but maybe pointing to some systemic racism in our hospital admission processes. We published this work in JAMA Network Open, and Kevin had a really good idea to just let UCSF know that we were going to publish this. And this kind of spurred a national news cycle that really generated a lot of interest in our work. So NPR covered it, Forbes published a whole article about this, New York Post, and lots of different people kind of covered this work, which is fun. Just taking a quick look for fun at some of the semen studies that we looked at. I worked with Jim Smith on these projects. This is for fun, and I'm getting close to time, so I'll just fly through it. But basically, I was curious, what is a normal amount of semen, sperm to ejaculate? And basically, I wanted to characterize the distribution of ejaculated seminal volume in people of different ages and different abstinence times. And the rationale is, there are a lot of supplement companies that attribute virility and male self-worth to ejaculate volume. And so what we did is we basically took all of the gentlemen that were consented for research in the Fellow database. Fellow is a mail-in semen analysis company, and we made a histogram of ejaculated seminal fluid volume. What it looks like is the vast majority of people had seminal fluid volume around 1.5 to 4.5 cc's, with median about 3.1. And then you see the super long tail of quote unquote super shooters who have extremely large volumes. The max was about 14.5 cc's. We compared this over age, and there, as you can see here, it's kind of a consistent downward trend with age. As if we look at the median and mean numbers, it slowly decreases in different age brackets, and also by abstinence time, as you can imagine, as you wait longer, the volume increases, but it plateaus after about 84 hours. So overall here, we did have a pretty productive year. I just wanted to share some of the projects that got published here. These are all projects that our groups completed, and there are several more in the pipeline that are coming up as well. And so in terms of research takeaways, in terms of data takeaways, I think that for the spina bifida work, there's a lot of preventative healthcare work that can be centered around the transition to adult care for individuals with spina bifida. And we saw that specifically with the increase in ED utilization in spina bifida people across all ages, but particularly as they transition to adulthood. For e-bikes, I think one of the big takeaways is that this is a real big growing issue. I think helmet use in e-bike wearing is really important, and maybe especially since helmet use is even less common than in bikes, conventional bike use. This is something that maybe from a policy standpoint, we can maybe seek to address. And for the fun semen analysis project, abstinence time plateaus at around 84 hours in terms of seminal volume. And then you actually do have, predictable slow decreases in seminal volume with age. And then more importantly, maybe the process takeaways are that research is a big group effort. I was able to get involved with a lot of projects, but I was, of course, not doing everything at all. I just was able to contribute specific things to push these projects across the finish line. And so my recommendations for other residents would be find what you like and what you're good at. For me, that was writing and asking provocative questions. And then with the e-bike stuff, promoting our work kind of got a lot of attention. So if that's something you're interested in, UCSF can help with that. Collaborators, lots of collaboraters here. Special shout out to Ben, Lindsay, Hillary, Jim Smith, and Fan, Kevin, and Debbie, who are in the trenches with me a lot, and then my family as well.
Thanks, Adrian. It's wonderful. And I forgot to mention, Adrian's going to be joining a urology group in Marin. So we get to keep him close by next year, which is very exciting. Last but not least, I'll introduce Dr. Farnoosh Nigad. She's our other chief resident, and Farnoosh is going to be joining our faculty at UCSF after graduation. So Farnoosh, come take it away.
All right, hello everyone. Thank you for the honor of presenting our work today. I'm going to be talking about prostate cancer and PSA screening in transgender women. So this is the funding that's helped to support this work, as well as my disclosures. So our main objectives will be to review the work that we've done over the past 6 years, starting from creating a database of transgender women within the VA, understanding prostate cancer characteristics at the time of diagnosis, review what we know about PSA screening thus far, and I'll end by talking about lessons I've learned throughout this process, as well as next steps. So first, just to take a step back, it's estimated that roughly 1% of the US population identifies as transgender. Despite significant ongoing marginalization and discrimination that this group disproportionately faces, that number is projected to increase. So it's likely that all clinicians, and in particular urologists, will care for transgender patients at some point. Now, the impact of gender affirming hormones on prostate cancer risk remains unknown. There's data that some of the gender affirming hormones decrease the risk of prostate cancer, but there's also data that gender affirming hormones may increase the risk of certain prostate cancers as well. Importantly, the prostate is not removed in any form of gender affirmation surgery, and thus all transgender women remain at risk of prostate cancer and should be considered for PSA screening. Now, when we first started this work, we wanted to better understand prostate cancer in transgender women. But what we found was that there's surprisingly very few studies on this topic. In fact, the data were limited to only 10 case reports and very few other studies. So we wanted to first conduct a national study to better understand prostate cancer in this population. But we actually encountered a very interesting dilemma, which is how do you even identify transgender patients within the EMR? So a lot of clinical research relies on the use of ICD codes to identify the cohort of interest. But in the case of transgender patients, there is no ICD code for transgender identity. And a lot of the codes, in particular before ICD-11, rely on very outdated and problematic language, things like transvestic fetishism and other terms that may not be accurate and often are very stigmatizing and simply just don't accurately capture transgender identity. Additionally, clinician notes are often inaccurate and inconsistent and may rely on the patient's legal sex or their birth sex, which in the case of transgender patients won't capture their gender identity accurately. Finally, the use of codes related to gender affirming hormones or surgeries is also in and of itself not reliable because not all patients undergo those therapies. So we first conducted a national study within the VA where we looked at the most commonly used ICD codes related to transgender identity, and we performed detailed chart review after stratifying patients by bilateral orchiectomy status in order to confirm transgender identity and test the sensitivity of these codes in identifying transgender women within the VA. Once we had the ICD codes that were reliable in identifying those patients within the VA, we were able to then have a reliable means of identifying those patients. And that was really the key that paved the way for a lot of the work that was to come. So through this, we created the nation's largest database of transgender women with about 15,000 women, or 15,000 transgender women currently and counting. And interestingly, we saw that despite shifts in politics, there's been a significant increase in the number of provider-driven entries of transgender identity in recent years. In fact, 75% of the provider-driven entries of transgender identity have taken place between 2011 and 2020. So once we had an accurate means of identifying transgender patients, we then returned to the work we originally wanted to do, which was to conduct a national study describing prostate cancer characteristics at the time of diagnosis in transgender women, and to also estimate the number of cases of prostate cancer in this population per year. So to accomplish this, we performed a retrospective study of adults ages 18 and older within the VA between January 2000 and November 2022. Patients with both an ICD code for prostate cancer and an ICD code related to transgender identity were queried, and detailed chart review was performed to verify transgender identity, confirm prostate cancer diagnosis details, and also look at gender-affirming hormone therapy usage. So in total, we identified 155 patients on chart review who were confirmed to be transgender women with prostate cancer. Now, estrogen was by far the most common gender-affirming hormone therapy used, so patients were stratified by their estrogen usage. 116 had never used estrogen, 17 had formerly used estrogen but had stopped by the time of prostate cancer diagnosis, and 22 were actively on estrogen at the time of prostate cancer diagnosis. In terms of our overall results, the median age at diagnosis was 61 years. And in our population, 88% were white with only 8% Black. And the median PSA at the time of diagnosis was almost 7. So In terms of our estimated number of cases, we expected 33 cases per year using estimates from cisgender male veterans. However, using the median year of transgender code entry into the chart, that created 11 years of follow-up. And with a previous estimate of about 10,000 transgender women within the VA, we ultimately had 14 cases per year per 10,000 transgender women. So just under half the rate of that of cisgender men. Notably, PSA density, which as we know is a measure of prostate cancer aggressiveness, was highest for those who were actively on estrogen at diagnosis. And there's an interesting or increasing trend as shown here. Additionally, the highest percentage of grade group 5 disease was also seen in those who were actively on estrogen at diagnosis at 29%. So this is compared to only 12% of never estrogen users and 6% for those who were formerly on estrogen. And as a point of comparison, about 16% of cisgender male veterans are diagnosed with grade group 4 or 5 disease. So the most important findings from this work were that prostate cancer does exist in this population, and it is not as rare as prior case reports may suggest. Nonetheless, our rates were lower than expected. And though our numbers were very small, there were trends that transgender women who were actively on estrogen had higher rates of grade group 5 disease and higher PSA density, both of which suggest potentially delayed diagnosis. So it's unclear if the lower rates of prostate cancer are due to underdiagnosis versus prostate cancer actually being lower in this population, or potentially both. There are several factors that might be at play here. So this may include lower rates of PSA screening in this population, a lack of awareness of prostate cancer risk by both patients and clinicians. It may be due to the suppressive effects of estrogen on prostate cancer development and biology. And perhaps most importantly, it may also be due to prostate cancer being missed in this population because of misinterpretation of PSA values for those who are on gender affirming hormones. PSA reference ranges are all set based on data in cisgender men. But we know that for transgender women who are on gender affirming hormones, we would expect their PSA values to be far lower. Thus, a normal value in a transgender woman who's on estrogen may actually be very concerning and warrant further evaluation. So this brought us to our next study, which was to explore PSA values in transgender women who were on gender affirming hormones. For this study, we looked at prostate or PSA screening values in transgender women who were actively on estrogen who did not have known prostate cancer. And the reason we specifically chose estrogen was because this is the most common form of gender affirming hormone in usage. So to accomplish this, we performed a retrospective study of all veterans between ages 40 and up from January 2000 to August 2023. And we specifically identified patients who had at least one code related to transgender identity and no ICD code for prostate cancer. We then performed detailed chart review on 1,000 randomly selected patients to confirm transgender identity, a lack of known prostate cancer, to confirm they were on estrogen for 6 consecutive months, and that they had also had a PSA test between ages 40 and 80 after they had been on estrogen for 6 consecutive months. In total, 210 transgender women met inclusion criteria, and there were a total of 852 tests. The median age at the time of PSA testing was about 60 years. And in this study, 81% of our population was white with only 2% Black. So this is the distribution of the PSA values that we found in our cohort. So notably, the median PSA was 0.02 with an interquartile range of 0 to 0.2. The 95th percentile in this cohort was 0.6. In this violin plot, the rectangular shaded area shows the interquartile range, and that little tiny white dot is the median. So in conclusion, the median PSA was far lower in transgender women who were on estrogen compared to age-matched references in cisgender men. So what's clear is that the existing reference ranges are far too high for transgender women who are actively on hormones, and the clinicians should interpret PSA values in transgender women who are on estrogen cautiously, because a quote normal value in that population may not actually be normal and may warrant further evaluation. Now, interestingly, in both this study and our prior study, we identified a disproportionately low percentage of Black transgender women. And so this suggests that there's disparities at the intersection of race and gender identity that we hope to explore further. And finally, though this study was an important first step, we need dedicated studies to establish proper cut points to use in this population. So this is some of the papers we've been able to publish for the past 6 years. And additionally, we've been very fortunate to have this work featured in different news articles, as well as in webinars, including one from the AUA. So we've been very fortunate to have this work get out to clinicians and patients so that everyone can be more educated on this topic and better care for our transgender patients. Most recently, this work was also incorporated into the 2025 NCCN Prostate Cancer Early Detection Guidelines. So for the first time, there's now guidance on how to interpret PSA values in this population. So now I'll transition to a few of the lessons I've learned, particularly for my co-residents. The first is that rigorous clinical research is very challenging and requires a lot of perseverance. So I've shown you today a body of work that took 6 years to build. But what I didn't show you was the countless hours, many late night phone calls and meetings, many rounds of revisions, and all the work that went into this in order to get to this point, as well as all the challenges and hiccups that we've had to overcome along the way. The second was research year is a really valuable time to develop new skills. So identify what you're interested in and try to work towards skills to set you up for that. For me, that meant completing a year of rigorous coursework in statistics and HSR and epidemiologic methods through the Ticker program at UCSF to better equip myself with skills that will hopefully set me up to be an early investigator. And finally, having a mentorship team is really crucial. So find people who will make time for you, really be in the trenches with you and inspire you. For me, this is that team. I'm very grateful to the people here who really made this work possible, because without them, none of this work would have been possible, and many of them are in this room. Now, I've also done a lot of work focusing on frailty with Dr. Susskind, so she's not on this slide because this talk was specifically focused on transgender, but I also wanted to acknowledge the importance of her mentorship as well. So finally, I want to also acknowledge the question that's probably on many people's minds, which is, where does this work go, given the challenges in funding in this arena currently? And I'm very passionate about this work, and I do want to continue it and will be continuing it on the side. But as a next step, I plan to apply the HSR skills and data management skills I've gained through this process and look to benign urology as I shape my clinical practice as well, to expand this work and to start to work towards being an independent and funded early investigator. And with that, thank you for your time, and I'm happy to answer any questions.